Hello and welcome to the Family Heart Foundation LP Little A Community Forum. Our topic this year is living with high lipoprotein A, managing risk and managing stress. My name is Kat Davis Ahmed and I work at the Family Heart Foundation, and I'm just really thrilled to bring you this conversation that we have with Jenny and Lawrence, our panelists, hosted by our Chief Medical Officer, Dr. Mary McGowan, speaking about what it's like to live with high lipoprotein A. Next slide. So I'm glad to see people are introducing themselves in the chat. We want to make sure that we say that this presentation is not to be considered medical advice. We're very happy to help you through our Care Navigation Center to find an expert who can help you if you need personal care, and this will be an educational event, but not something that you should take as your personal medical advice. And we're thank you all for introducing yourselves in the chat. It would be great if you say hello. Make sure you choose everyone as a choice when you click on chat, as opposed to choosing host and panelists, so that everybody can see your post. And if you already posted to host and panelists, then please go back and post again to everybody, because we would like you all to connect. Even if it's just virtually through chat. Say your name, where you're from. Great to have you here. During the course of the presentation, please feel free to put your questions in the Q&A. You can also put your questions in chat, and we will capture them and get to those questions after the panel discussion with Dr. McGowan, Lawrence, and Jenny. So we'd really like to thank the sponsors, the supporters of our Lipoprotein A Community and Action Program for 2022. And those are Amgen, Konica, and Silence, and of course our Family Heart partners, families and individuals who step up to support the work of the Family Heart Foundation. We could not do these programs without you. And with that, I'd like to introduce Dr. Mary McGowan, Chief Medical Officer at the Family Heart Foundation, who will give you a brief overview of lipoprotein A, and then moderate our panel discussion and answer questions at the end. Welcome, Dr. McGowan.
Thanks so much, Kat. Welcome to everybody. I see we have a big crowd here tonight, and that's great. This evening, we'll be discussing how to manage the risk and stress of living with elevated lipoprotein A. Last year, when we did our community forum, we talked about the importance of getting tested, and that's still important. But we've heard from lots of people over the course of this past year about the stress associated with living with elevated lipoprotein A. We'll have the opportunity to hear from our panelists, Jenny Ray and Lawrence Durek, about their perspectives on this important question. We'll begin, though, briefly about discussing, what is lipoprotein A and why are we concerned when it's high? Now, this may be review for some of you on our webinar tonight, but I think it's worthwhile to go over the basics of LP-A, and I'm only going to be going over the basics. So I would suggest that if you want or need more information, you should check out our Family Heart Foundation webinars, because they go into a great deal of detail. The Family Heart Foundation's research shows that very few people have had their lipoprotein A tested in the United States. In fact, fewer than 0.3%, so less than 1% of Americans have been screened. But once somebody is tested and found to have an elevated level, we want to help you figure out what to do with that sense of stress that some people feel. Our topic of discussion is important because we do hear from a lot of people once they've discovered that they have high LP-A, that they need to know what to do next, especially as treatment options are currently quite limited. The most important perspective, as I've said, that we can get on this question is from patients and families. These are the people whose lives are impacted. And to this end, as I said, we'll have the opportunity to speak to two Family Heart Foundation advocates whose lives have been quite substantially impacted by high lipoprotein A. So this very first slide tries to answer the question, what is LP little a and how does it increase our risk for cardiovascular disease? Lipoprotein little a is actually quite a complex lipoprotein. And I don't have a pointer here, so I'm going to direct you to the various aspects of LP little a. So LP little a has an LDL-like core. And so I'm sure most people on this, oh, thank you very much, Megan. Most people on this call know that LDL is also known as the bad cholesterol. And as the bad cholesterol, it can get into the artery wall. And so we call that proatherogenic, likely to cause atherosclerosis. So that's part of LP little a. Another part is you can see this ApoA, which is apolipoprotein A. It's what we call an apolipoprotein A tail. And this apolipoprotein is actually attached to the ApoB portion of LDL, and it's attached via a disulfide bond. ApoA, suffice it to say, is it mimics something called plasminogen. Plasminogen gets converted to plasmin, and it's plasmin in our bloodstream that breaks down fibrin clots. And in fact, in our bodies all the time, there are little clots forming and we break them down. But this ApoA tail looks very much like plasminogen, but it doesn't behave like plasminogen. And so it sort of interferes with plasminogen's work. And as a result is what we call prothrombotic, likely to cause thrombus. And then finally, you'll see up in the upper right-hand corner is oxidized phospholipids, those depicted as little orange balls. Oxidized phospholipids are pro-inflammatory. So LP little a is sort of the triple whammy. Proatherogenic, meaning it can cause plaque, prothrombotic, meaning it can cause clot, and pro-inflammatory, meaning it can inflame the blood vessels. And as a result, there's an increased risk for heart attack, ischemic stroke, and aortic valve stenosis. It's believed that the oxidized phospholipids actually can sort of make the cells of the aortic valve behave like bone cells, and you get a very calcified aortic valve. Now, we want calcium in our bones, but we don't want calcium in our aortic valves. Next slide. So you might ask the question, how high is high, or what's a high level? So a normal level is less than 30 milligrams per deciliter, or less than 75 nanomoles per liter. LP little a is a little tricky because it can be measured as both in milligrams per deciliter or nanomoles per liter. Nanomoles per liter is really the preferred way, but if you've been measured in milligrams per deciliter, it's still a valid test. There are some organizations that differ a little bit on what is considered high. The American Heart Association and the American College of Cardiology say elevated is greater than 50 milligrams per deciliter or 125 nanomoles per liter. The NLA, the National Lipid Association, differs a little bit, says elevated is greater than 50 milligrams per deciliter or greater than 100 nanomoles per liter. Next slide. Oops, back one. So to get to that question of what can I do if I have a high LP little a, if I don't have a medication that I can take currently? I usually point my patients to the EPIC Norfolk trial. This was 14,000 individuals, and they looked at those people whose LP little a was greater than 50 milligrams per deciliter, so high, and followed them for 11.5 years. And they asked the question, if you have very few cardiac risk factors and you have a high LP little a, is your risk lower than if you have lots of cardiovascular risk factors and you have a high LP little a? And they called high the reference range. You can see that in red there. Individuals who were low for these risk factors, smoking, overweight, diabetes, hypertension, high cholesterol, physical inactivity, or an unhealthy diet, their risk was 66% lower of having a cardiac event during those 11.5 years than individuals who had multiple risk factors. So one thing that we can do is stress the importance of getting rid of any risk factor that you do have. Next slide. And one of those risk factors could be high cholesterol, high LDL cholesterol. And so we do stress that people with high Lp(a) should get their LDL as low as possible. So for people who have not had a cardiovascular event, that LDL goal or safe zone would be an LDL less than 100 milligrams per deciliter. If you have already experienced a heart attack or stroke, then that LDL goal is less than 70. And we now have new guidance from the American College of Cardiology in 2022 saying people who've already got heart disease and have multiple other risk factors, familial hypercholesterolemia, high Lp(a), hypertension, diabetes, their safe zone might be trying to get their LDL less than 55 milligrams per deciliter. So pushing on that, as well as those other risk factors, is going to be very important. Next slide. Lipoprotein apheresis is one treatment that is currently available for both LDL and lipoprotein(a). Pictured here smiling is one of our family heart advocates, and she gets LDL apheresis on a biweekly basis. The way apheresis works is they take advantage of the fact that the Lp(a) and LDL both have ApoB on their surface, and ApoB is positively charged. And so blood is withdrawn and separated into both plasma and red cells. And it's the plasma that goes through those two little columns called lipoabsorber columns. Those columns have negatively charged dextran sulfate in them. And so when the plasma goes through, the negative charge from the dextran sulfate and the positive charge from the LDL and Lp(a), they attract each other, and we can get rid of LDL and Lp(a). It's a removal system, but the LDL and Lp(a) come back, and and so this has to be repeated every couple of weeks. Next slide. We do have some clinical trials that are ongoing for Lp(a) reduction. So pelacarsen is one such agent. It is in a class of drugs called antisense oligonucleotides, and this is being developed by Novartis. It can lower Lp(a) by 38 to 80%, but the dose that they are using in the Horizon trial is a dose that's likely to lower Lp(a) by about 80%. This drug can also lower that oxidized phospholipid that I talked about is part of Lp(a) that increases the risk for inflammatory effects. So the Horizon trial is a trial that is ongoing. It includes roughly 9,000 patients. It's what we call a phase 3 cardiovascular outcome trial. Enrollment was completed last spring. In order to be in the trial, people have to have had an atherosclerotic cardiovascular event, a heart attack, a stroke, peripheral vascular disease in the last 10 years to enroll. Patients get 80 milligrams by subcutaneous injection once a month versus placebo. And as I said, it's estimated that this will lower Lp(a) by 80%. And this study, they believe, will continue for about 4 years or until 993 events have occurred. Next slide. Olpasiran is a small interfering RNA, so slightly different mechanism of action. Amgen has completed a 281-person phase 2 study, 4 different doses, 10 milligrams of olpasiran every 12 weeks, 75 milligrams every 12 weeks, 225 every 12 weeks, and 225 every 24 weeks. And the inclusion criteria for this particular trial, you had to have a lipoprotein(a) greater than 150 nanomoles per liter. But what they found in this clinical trial that is now complete was the baseline level was roughly 260 nanomoles per liter, so very high. And these people had to have evidence of atherosclerotic cardiovascular disease. The study findings were published in the American Heart Journal, in 2022 and found that patients who received 75 milligrams or higher every 12 weeks lowered Lp(a) by 95% or more compared to placebo. And this was at 36 weeks. 98% of people achieved an Lp(a) less than 125 nanomoles per liter. Next slide. So Amgen has now moved on to using olpasiran in a cardiovascular outcome trials called Ocean A. It is enrolling, and it will enroll until it has 6,000 patients. Patients can be considered if they're between the ages of 18 and 85. They have to have an Lp(a) that's greater than 200 nanomoles per liter. They have to have a history of a heart attack and or coronary revascularization with a stent and one additional risk factor. And there are multiple sites in the United States recruiting for this now. Next slide. Lilly is also recruiting, and their agent is an oral agent for Lp(a) reduction, and their study is now recruiting. This is a phase 2 study, so it's not going to be as long as, say, the Amgen study, which is multiple years. This is I believe it's a 36-week trial, but I'm not 100% sure here. It's a phase 2 randomized double-blind placebo-controlled trial. So there will be people getting the active drug and people getting placebo. There are 3 different doses of the LY3473329. So that's the name of the drug at the moment. And the adults that will participate, they have to be over 40. They will be adults who are at high risk for cardiovascular events. And high risk for cardiovascular events is defined as having documented coronary artery disease, stroke, or peripheral artery disease. That's blockages in your legs or your neck, your arms. And they could have an atherosclerotic cardiovascular risk equivalent. And what they're calling risk equivalents are familial hypercholesterolemia or type 2 diabetes. And in this case, you have to have an Lp(a) greater than 175 nanomoles per liter. Next slide. Very last agent that I'm going to talk about, Silence Therapeutics has SLN360. This is another small interfering RNA. This is a study, a phase 2 study, studying 160 patients, ages 18 to 80, evaluating 3 different doses of SLN360 versus placebo in people who have an Lp(a) greater than 125 nanomoles per liter who are at high risk. The study began just this year and will be treating patients for 36 weeks. And I think that's my last slide. No, this is a program that we have. If you want to find one of these clinical trials, you can visit familyheart.org /clinical trials, and you can find a clinical trial in your area for the disorder you're interested in. It's a lot easier to go here than to go to clinicaltrials.gov. We simplify things for you. Next slide. And if you want to learn more, we have lots of webinars that you can listen to even after they've been done. So they're available on our website under webinars. Next slide. Oh, and we have a webinar coming up. And I think I saw my co-host Allison sign into the program tonight. So we're looking forward to talking about homozygous FH and the advances. Thanks, Allison. Great that you're here. And then I invite you to visit our Care Navigation Center. We have a dedicated Care Navigation Center, and we can help people find clinical trials. We can help people get answers regarding FH or high Lp(a). If people are having struggles with insurance companies, we can help you with that as well and answer your questions about high Lp(a) or FH. So without further ado, I'd like to introduce our panelists, Jenny Ray and Lawrence Durack. I'd like to ask each of you to introduce yourself, tell us where you're from, what you do for work, what you do for fun, or both. Tell us a little bit about how you learned that you had a high Lp(a), and maybe a little bit about your family history. Do you have relatives with early heart disease? And did you ever wonder yourself if you might be at risk?
Hi, my name is Jenny Ray. I live in Columbus, Ohio. I saw there was a couple of other folks from around here. I am, let's see, I'm trying to think of all the things you suggested. I work full-time at a small art and design college here in Columbus. I have a child who's 5. I have a dog who's much older, who you may hear in the background if I don't get properly muted at certain times. I'm married. In my free time, when I have it, I like taking advantage of my workplace's free art classes. And so I get to take some ceramics classes, some jewelry making classes, things like that. The way I found out about my elevated lipoprotein little a was in October 2019. So I was 41 at the time and I had a 21-month-old child. I ended up having a heart attack, which was very unexpected. I'm a vegetarian, I'm a non-smoker, all those sort of things. I thought I had a pretty healthy lifestyle, and in fact had a cholesterol test just that week that showed me to have an LDL of 65. But I did end up having that happen. Prior to that, my dad had 3 heart attacks, despite being a very active person. He was sort of the first person I knew of in my family to have any heart issues or stroke issues. And his doctors at the time had sort of generically told him, you know, you have 2 daughters, you might want to talk to them about having their levels sort of assessed just in an overall, like, you know, to look at their lifestyles, to get sort of baseline information. And so as the timing would have it, literally the week of my heart attack, I was meeting with a new doctor who had put in orders for an EKG, an ECG, different things to get a sense of where I was in terms of that health. And unfortunately, I wish I'd had that appointment about a week earlier, because we would have known a little bit more about my health factors. But I did indeed have a heart attack in October of that year 2019. And then in January, right after that, my family physician suggested I have my lipoprotein little a tested. And so from there, we subsequently found that my dad did indeed have a high level. My sister has a slight elevation, but not anything that her doctors, at least at this point, feel too worried about. And then my son has, luckily not as elevated as mine, but also has elevated lipoprotein. So that's my story.
Thanks, Jenny. And Lawrence?
Oh, hi. My story, let's see. I live in Seattle, and I moved from Ireland in 1990. People joke with me, why did you go from one rainy place to another rainy place? But actually, Seattle is so beautiful. I'm starting this webinar today. I was like, oh no, we have a really sunny day today, and I wanted to go out on a hike because I love going out on hikes and all that. Well, to start my story about my illness, I'm going to start at the end and tell you that I have a really high LPA. I've been told it's in the top 0.1%. And then not too long ago, I found out I had multiple silent heart attacks. And I'm also on the drug trial. But how I got to this stage is kind of interesting, because I thought I was doing great. I'm a pretty healthy guy, and I'm always out exercising, doing everything. I look after my diet, I did everything right. And in 2019, I wasn't feeling good, and was diagnosed as allergies or something. I had a pain in my throat and headaches and just not feeling good. Then I decided I'd switch doctors, and the next doctor says, oh, let's do an EKG. Then I found out, I had a stress test. And next thing I knew, I had 4 stents. I had 3 blockages, and they could only fix 2 of them with 4 stents, and they left the other one. Because I had good collaterals letting me know that this thing had gone on for years. Okay, that was 2019. 2020, on Valentine's Day, I was going to do something with my wife when I actually ended up collapsing at work, and I ended up in hospital for 2 days. And I still remember the sandwich I had in the hospital. It was pretty dried out and pretty bad. So our meal plans were ruined for that day. Anyway, it was a lot of the medications I was on. And then for the next year or more, I just had trouble with medications. I tried lots of things. But then my cardiologist left town, and in 2021, I had a new one, and he says, oh, we should do a stress test again. And that's when they recommended I get get in and get another stent, and I cleared up the blockage in my LAD, and that was wonderful. Then my new doctor says, you know, you're too young. And like I think I forgot to say that I was born in 1963, the same year they discovered LP(a). I says, wow, what a great year to be born. But he said, have you heard about LP(a)? And I says, no. And he says, you know, would you like to do the test to find out if you have it? Because it doesn't seem right that you have all these blockages. And I says, but he warned me. He says, you know, we've no cure or anything. And I said, do you really want to do it? And I says, yeah, I want to do it. I'm an engineer. I like the data. Just give it to me. So he did. And I found out that I had that really high LP(a). And then I said, is there anything I can do? And he says, well, no. But I said, is there any trial or anything? And he says, oh, well, yeah, but you have to have an event or something. And then they went through things and they said, well, you actually did have an event. And that was the first I had heard anyone say to me that I actually had a heart attack, because I don't know when it happened. And he's probably had more than one with the damage in my heart. So I did get into the drug trial, and here I am today. It's been a really interesting journey the last 3 years. And I'm glad to say that this year I'm actually feeling pretty good. So it's just so interesting. And just one last thing I have to say, how thankful I am to the Family Heart Foundation, because once I found out, they've been just so wonderful, the information. And for me, the emotional aspect, it's the stories. That is what keeps me going. When I read about other people who have what I have, because it's hard with my friends. They look at me at times and like they don't understand. So that's my story.
Thanks so much, Lawrence. And, you know, I think, unfortunately, many of your friends do have high LP(a), since we know it occurs in 1 in 5 people in the United States. It's just the fact that they don't know it at this point. But one of the things I wanted to ask both of you, and we'll start with you, Jenny, and then you, Lawrence. In my introduction tonight, I mentioned that many people feel a tremendous amount of stress associated with knowing that they have the high LP(a) and that they don't necessarily have a medication that they can take at this time. Was your diagnosis very stressful for you? And if so, how do you deal with it? And what advice would you give the people that are looking, watching you tonight, about how you would best deal with it? Jenny?
Yeah, so yes, there was a lot of stress involved in the whole situation. You know, just going back to my heart attack, I did go into cardiac arrest while I was in the hospital. So that was clearly very scary. And then coming out of it, you know, I had about a 3-month period, 3.5 months or so, where I hadn't yet heard of LP(a) and sort of was just trying to figure out my new life with that. And then when I took the test, and probably other people in this call use my chart. That's what I use to get test results. So I happened to see the test results come in before I even had a chance to talk to my doctor. And I sort of saw the number, and immediately I have a background in sort of journalism and somebody who is just very much like, okay, I need to learn as much as I can as immediately as I can. So to do that initial kind of information seeking, as I'm sure a lot of people do, to read that, oh, doctors have known about this since the 60s and there's still no kind of official treatment for it, and to have seen, you know, how close I'd come to death so soon before that was really scary. You know, I said before, it was sort of like, it was terrifying at first, and I still get a little emotional about it, but luckily, you know, I had already, as it happened to be, I've had great timing and bad timing for different reasons, but had already registered for this workshop series about mind-body stress reduction, a meditation series that's sort of based in science. And so I had started, actually, I'd already signed up before my heart attack, and it actually started the week after my heart attack. So I had started this kind of very science-based meditation practice that I found really helpful, because I developed some true bad sleep issues after leaving the hospital. I started taking, you know, some anti-anxiety medicine, which was helpful. I talked to people and found support groups, online through Facebook. And then, of course, finding the Family Heart Foundation was huge, as Lawrence said, to find other people and to hear sort of experts sort of talk about it. For me, it was kind of finding ways to sort of take control of my story, to gain more information about it, but also, to say, okay, well, there isn't treatment, but like, what can I do within the context of that to sort of make, to deal with some of those risk factors, so I got a personal trainer and I work out twice weekly with a trainer. I try as much as I can, being a parent and a full-time worker and all those other things, a wife and a daughter and a mother, to try to reduce stress and to try to enjoy, creative practices and things like that. And some days are better than other days, but I am so glad that I know about it and that I can help other people sort of navigate and hopefully avoid the situation that happened to me.
That's wonderful, Jenny. Thank you for sharing that. And thanks for sharing that you're doing the meditation and considering taking anxiety medications. I mean, some of these things, it's really helpful to speak to a professional, and it sounds like you have. Lawrence, how was it for you?
Well, yeah, first thing to say, your introduction to this webinar was amazing. It's really interesting. Every time I see the picture of that LP little a, my stress goes up.
Oh, I'm sorry, Lawrence.
It's really interesting. It's like I actually do really well, but it's so interesting. Every time I read about it, and you just see how awful it is, and I can see how people get really stressed out. When I first got my results, I got so depressed. It's just like, and anyone who knows me will know that I'm a really optimistic person, and things don't get to me that much. But when I first got that news, it was devastating. It was just like, wow. And it was the nurse who called me and says, yeah, here's your number. Here it is.
Do you
And
remember
like,
what it was, Lawrence? Or do
yeah,
you
it
don't
was,
feel that you have to share it if you don't want to?
no, it's fine. They said it was 248.
And
That's
was
what
that
it was. Nanomoles.
Okay.
Nanomoles, yeah. And that's when the cardiologist says, oh boy, yeah, you gotta be that. This explains a lot. And so there's the part where I felt like, wow, this is great. I finally have a reason.
Yeah.
For what's happened to me. So there was the positive aspects, like, oh my God, I finally have a reason. But then there was also the other side. Oh, the reason isn't what I'd like it had been. I
Mhm.
can't fix this with my diet, with my exercise, with stress, with all these things. I have to do everything possible. And I think I've told you before how I love my statin. I love all my medication. I am going to do everything I can to reduce the risk. And I'm an engineer, so I understand risk. And I was thinking to myself the other day with, we all have to live with a risk. I live in Seattle where we could have an earthquake all the time. And so what I have to remember is, even though we could have an earthquake, there's lots of things you can do to lower your risk. And so once I realized that, it's like we all have these risks all the time. And then that I'm in this drug study, I may or may not be getting it because it's 50-50 whether you get it or not. But my view is I am going to do everything possible to lower that risk. But the initial few weeks, I went through a very dark phase. It's like, wow, is there any hope? And and actually today I was just on the Facebook group you have, and I just see that from other people once they learn. It's just such an awful thing to hear when you first hear it.
Thank you for sharing. I'm glad that there are some good days. And, I wonder if you could each discuss how you came to the decision to enroll in the trial. Was it an easy decision? Were you concerned that it was 50-50 chance, as it has to be to determine whether or not the drug is safe and effective? Jenny, I keep picking on you first. Maybe you give Lawrence some good ideas what he's going to say.
Yeah, for me, after I kind of went through that diagnosis of finding out that I had the elevated lipoprotein A, I talked to my doctors about what are the options available to me. And, we talked about the I always get the letters confused, but the PCSK9 inhibitors, my insurance unfortunately rejected me for that. We looked at different kind of possible treatments. I was sort of in the bind of having good cholesterol, which actually then for treatments like apheresis, they said, no way will you get a treatment like that. So for me, you know, the opportunity to be a part of the study was meaningful in terms of, you know, 50%, yeah, it's 50-50, but that's greater than 0%, which was what I was experiencing without being part of the study. And for me, you know, it gave me hope, and it gave me hope for my child and for other folks. So it felt like a no-brainer to me, you know, I was thrilled.
That's wonderful. And Lawrence, was it similar for you?
Yeah, for me, it was actually a pretty easy decision because I'm an engineer. I used to joke to people for years. I said, I'd love to work in research. And I didn't realize this is the way I do the research, but I'm just glad to help. I'm always the type of person like I'd eat a meal and I'd often say, God, I'm really glad our ancestors figured out which food is okay to eat. So, and I've actually often appreciated people who did the trials for the statins I'm on too. And so in the big picture, even if I'm not getting it, I felt like, wow, this is for the greater good. And so for me, it was actually a pretty easy decision. And there's quite a burden to go on these things too, because I've had to go in lots of times. So but my feeling was I'm doing it for the greater good.
That is wonderful. And we really do thank you. We encourage people to participate in clinical trials because it's so important to get this information. Jenny, I wanted to talk to you. When we were preparing for this, we were talking about some physicians who give people a hard time and say, I'm not measuring your Lp(a). There's nothing we can do about it. I don't know much about it. And you told me something that I thought was very interesting. You said that if you had known your Lp(a), you would have had a different behavior with that chest pain.
Yeah. So, you know, going back to some of the parts of the story I shared before, you know, my dad, who, you know, he also lives in Columbus, and I won't call out his medical team, but, you know, they had said to him, there might be family connection, but we don't know. He'd actually gone in, I think maybe I've said this already, he'd happened to go into cardiac arrest spring of 2019. So he and I both went into cardiac arrest in the same year, which is a terrible thing to share in common. Luckily, we both survived, but you know, but for whatever reason, they never mentioned the words lipoprotein(a), never discussed testing it. And so, you know, for me, I waited about 18 hours to go into the hospital, and it truly was, you know, one of those things where I had what I now understand are more of the classic kind of symptoms that a lot of women experience that are different than what you think of. Like, I didn't really have chest pain until the end, but I had this, you know, feeling of doom, and my both arms kind of hurt, and I had some just very strange sensations. But because I've had like anxiety in the past, you know, I was sort of like, well, this is a weird thing, but I think it's probably, you know, and I've even had friends who have gone into like an ER thinking they were having a heart attack, but it was really a panic attack. So given that I had, you know, good cholesterol, that I wasn't a smoker, that I was sort of doing all the things that you think of as being somebody, you know, 41 years old at the time, I just kind of discounted all of my symptoms, and it really was. So I went overnight, 18 hours. And as I said, the timing was such that my physician just less than a week before had put in orders for me to get an ECG and an EKG. And I'm ashamed to say I keep switching which is which, but I ended up going at my husband's insistence and getting that reading done the next morning. And the tech, her eyes went really big because apparently I was in the middle of having my heart attack as she was just reading for like a regular, you know, visit. And so they suggested that I go to the ER. And even then I felt like it was so much in my head that my husband really had to talk me into going to the ER, because I was like, I don't really want to be around other people. No, this is just all in my head. You know, and again, you know, having gone into cardiac arrest while in the hospital, I think had I delayed that treatment any longer, how it could have ended much differently. So, and on the other hand, I wish had I known that I had Lp(a), I would have taken my symptoms more seriously. We could have maybe sought some treatments or preventative steps or gotten earlier treatment. I would have, taken those symptoms more seriously overall.
Yeah, I think that you just spoke so eloquently. I think anybody listening, if you have any question, go to the ER. Don't delay. And Lawrence, I just wanted to, we're going to ask one more question, and then I can see that the chat is blowing up, and I'm counting on Kat to tell us what the questions are. But Lawrence, originally you're from Ireland. I'm Irish myself, and the European guidelines call for screening everybody at least once in their lives for Lp(a), so very advanced. And the Canadian guidelines call for exactly the same thing. In the United States, our most recent guidelines only say that Lp(a) should be considered as a risk-enhancing factor, that if it's available, they're not saying anybody needs to get it, but if it's available, that risk-enhancing factor could be used to help make decisions about lipid-lowering treatments. What would you say to our guideline authors?
My opinion is everyone should get tested because, for years I was really good. I got tests every year, my LDL and everything. And every year they tell me, oh, your LDL is a little bit high, but your HDL is high too. And the ratio is good. Your risk is really low. Don't have to worry at all. Then my family history, my parents, there was no one. I found out later that there's relatives on that had issues. But for me, I wouldn't have counted. I didn't have this family history of heart disease. And I can't tell you how many times I think about it, about what if. Like, I wish I'd known years ago. I'd have been on the statins, I'd have done things. Because I wasn't on any medication until after my event in 2019. So my view is that everyone should get a test. Oh my God, it's and I think we're really lucky too. Like, there's a lot of diseases where there isn't a marker you can measure. Like, it's amazing. Here we have something where there's a marker, and you can get the test. It's pretty cheap. It's a really cheap test to do. And I know they don't want to do it because there's no cure yet or anything. Oh my God. For me, I might be here. I might not be here talking to you today. I might not have had an event. So for me, I think everyone should get the test.
I'm with you. I fully agree. So I think we'll stop here. You guys have been amazing. I feel like I know you much better. I feel like our audience knows you, and you've really brought a lot of really useful information. And I think especially talking about how you felt when you got that diagnosis, I think it's helpful for other people to know that they're not alone, that it's a natural feeling to be very upset and stressed, and it is important to seek help for the anxiety associated with it. Kat,
wow. Thank you so much. That was really incredible. I learned a lot, and I know you inspired a lot of great conversation and questions in the chat and in the Q&A. So I have my work cut out for me posing these questions. And thanks to everybody for the terrific participation. So I have a few sort of questions to start out with. A few people have asked about, does Lp(a) fluctuate or change over time? Is it okay to have just one test, or do you test over time? And related to that, what can make your Lp(a) change from one test to another?
Yeah, that's a great question. So we used to think that Lp(a) was pretty stable. Recent evidence has shown that it increases steadily throughout childhood. And so we used to think that it reached its adult level by 5. That may not be quite true. And we know that certain things increase Lp(a). Pregnancy increases LP(a), acute illness. So at the time of your vascular events, Jenny and Lawrence, we shouldn't be measuring your LP(a). LP(a) is what's called an acute phase reactant. And what that means is it can increase substantially with an illness. It can increase substantially with COVID-19. And there may be an increased risk for people with high LP(a) to get into trouble when they get COVID-19. So trying to avoid COVID-19. The other thing that we know, and this is actually from the pelacarsen studies, the phase 2 trials, obviously some people got pelacarsen, which could lower the LP(a) as much as 80%, and some people got placebo, but they were all in a double-blind placebo-controlled trial, so nobody knew what they were getting, and everybody got the same tests. And so over the course of the study, people periodically got their LP(a) measured. And what was found in the placebo group, that LP(a) could fluctuate as much as 20%. So we do have a biological variation for LP(a). And if you get the flu, it's probably going to go up. So, those are things to be aware of, that it's not as stable a lipoprotein as we once thought. But if someone gets a reading that is high, your LP(a) is likely high, as long as you're in your usual state of good health at that time you get it drawn.
Thank you so much. And I think it's really interesting, not only so much of what we know about any treatment, right, and also about the conditions comes from the clinical trial studies.
Absolutely.
So I'm always inspired by the fact that it's not just, are you learning, does this drug work or not? You're also learning, what does this disease look like, and what happens when you change the things that you can measure, for example, lipoprotein A. So one question asked about that, how do we know that when you have that LP(a) is an independent risk factor? What do we know that indicates that it is? What if your LDL is controlled, either because you have a low LDL or because you are taking a treatment, including, for example, PCSK9 inhibitors are not approved by the FDA to lower LP(a), but they do lower LP(a). So if your LDL is controlled, what do we know about the fact that LP(a) contributes to cardiovascular risk?
Yeah, so we know that if somebody has a controlled LDL and they have an elevated LP(a), they're at less risk than if they had an uncontrolled LDL and an elevated LP(a), but the LP(a) still independently contributes. It roughly doubles the risk of a stroke and almost triples the risk of a cardiovascular event, independent of any other risk factors. And so, basically, when you do clinical trials, you can, or observational studies, you can control for other risk factors. And even, when you control for other risk factors, LP(a) is still an independent predictor.
Mm-hmm. And some of the research we're doing at the Family Heart Foundation and our Family Heart database is also looking at these questions about who's
absolutely
and what contributes to risk. So keep an eye out for our publications coming. Another question is about the relationship between having high LP(a) and having familial hypercholesterolemia. And I'll say sometimes people are told, or they think you have to have one to have the other. Can you talk about that, please?
Right. So LP(a) is very common. As we've talked about, 1 in 5 people in the United States, 1 in 5 people worldwide has an elevated lipoprotein(a). So 66 million Americans have a high LP(a). 1 in 250 people, roughly, have FH. So it stands to reason that some people who have FH will also have high LP(a). But it does, so FH is a distinct disorder, and high LP(a) is a distinct disorder. They can exist together. And we need to learn more about how common elevated LP(a) is in familial hypercholesterolemia. And we're doing some work looking at that. In the past, it was said that 50% of people who had FH also had a high LP(a). So those two disorders increase the risk. We now hear It's roughly 30 to 50%. And we will, with the Family Heart Database, be able to answer that as well. But it does appear that if you have FH, you're at higher risk than just 1 in 5 of having high Lp(a).
Thank you. So a bunch of questions are related to how you assess your cardiovascular risk, your risk for a heart attack, or your risk for one thing that hasn't been mentioned yet is the peripheral vascular disease or peripheral artery disease, and maybe aortic stenosis might be another one that people aren't necessarily aware of as a risk. What are ways people can understand what their risk is with tests and things like that? And should they be monitoring progression over time?
Yeah, so if somebody has a significantly elevated lipoprotein(a), and like Lawrence was having issues over a number of, I don't know if it was years, but like thought you had heartburn, thought you had all these things going on. One non-invasive test that is being used more and more commonly is called a CT angiogram. We can also do coronary CTs, but I'll talk about a CT angiogram first. A CT angiogram is an angiographic study that basically you're able to look at the coronary arteries without doing a catheterization. So you get good visualization of the coronary arteries, and you can see, a specific plaque. You can see, whether or not there's plaque that's 70%, that's 90%. And then a coronary calcium score. We have to caution people that often people with FH or high Lp(a) will have a normal coronary calcium score when they're young. In middle age, we can start seeing changes. And so when we get a coronary calcium score, we're looking at calcium in the coronary arteries. And the only place that calcium goes inside a coronary artery is inside plaque. So your calcium score is a marker for plaque burden. So that's worthwhile. When we look at other measures that are standardly used, things like the coronary risk factor scores. We can't use the coronary risk factor scores in people with FH or high Lp(a) because they don't include that as a risk factor. They don't factor that in. And so you get an erroneous lower risk. But there is a group in Spain that has a registry called SafeHeart. And they have developed a calculator that we can use. I have a son who's a math major, and I sent it to him, and it's still confusing to me exactly how to use the calculator, but I'm going to get to the bottom of it. And he's actually was a math major. He's now a medical student, so he better help me with it. But that would be worthwhile if we could use that kind of tool for people that have risk above and beyond things that are not used in the risk calculator.
Okay, thank you. And we had some great questions about that I think you answered about what were your Lp(a) levels and what were your symptoms. But I think with considering the time, the other question people ask is, who's Lawrence's doctor? Sounds like you have a good doctor. You guys could each give a shout out to your doctors. That I'm sure they'd appreciate it, and the people who live near you would appreciate it. And I would say also that if you are looking for somebody who knows about high Lp(a) or about high LDL and FH, contact the Care Navigation Center at the Family Heart Foundation. Just visit our website, familyheart.org, and there's a red button at the top, and you'll reach our Care Navigation Center, and we can help you with that. And also a lot of questions came in about, or comments, great encouraging comments about when you encounter problems with insurance coverage, either for treatment or for tests. We would love to hear from you if that's what you're experiencing, because we can help, but also we can take your story and your case and go to the insurance companies and say, this is what's happening with your members, and advocate on a bigger level. So please share those stories with us. So Dr. McGowan, it doesn't give you enough, but in 2 minutes, if you could talk about the role of different treatments. People are asking, does having high Lp(a) mean a different treatment plan? What's the role of statins, especially if they raise Lp(a)? Should you worry? What's the role of diet? What's the role of PCSK9 inhibitors and of apheresis? And finally, when do you think about those treatments? And then I think important to say that PCSK9 inhibitors are not specifically FDA approved for lowering Lp(a), though they do lower Lp(a). But what's the role of these different treatments?
Yeah. So one of the things that comes up very frequently is that the belief, and it is sometimes true, that statins can raise raise Lp(a). Statins can raise Lp(a), but they lower LDL so substantially that in someone with a high Lp(a), the first step is a statin. This next step is adding ezetimibe. And the third step would be a PCSK9 inhibitor. And we are really enthusiastic about these new clinical trials. They have to be done. These drugs have to be proven to be safe, effective at lowering cardiovascular risk. And it's not enough to just lower Lp(a), they have to lower risk. So we're very hopeful that within the next few years, the anxiety level for people will be lower because there will be great tools that we can use. And if you guys want to shout out to your primary care doctors or your cardiologists, go for it.
My doctor is my cardiologist, who's a lipidologist, also is with Ohio State, Dr. Maida, and I think she's listed on the Family Heart website, actually. And then my primary care physician who ordered those initial tests, her name is Dr. Christina Johnson, and they're both with Ohio State University, and they were great.
And Lauren?
Yeah, for me, first I'd say that I'd highly recommend people go out and get second opinions, because that really helped me. I highly recommend it. If you're not sure, get a second opinion. Even though I like my cardiologist, I also got another opinion from another cardiologist, and they kind of agreed in the end, and that was really good. But I'm at the UW Medicine, and it's a research hospital, and I think that helped a lot. And it's Dr. Dijek there, and he's
That's
really
great.
good.
That's great.
He's a really good plan of attack from.
Thank you so much. Well, I want to thank you all, Jenny and Lawrence and Dr. McGowan, and thanks to everybody who joined us. Thank you, especially when people shared really some powerful stories in the chat about their own experience and their family's experience. And, we feel you here at the Family Heart Foundation. And so I really invite you to apply to become an advocate for awareness, share your story. That's what Jenny and Lawrence are doing. They are Family Heart Foundation volunteer advocates for awareness. It's easy. We have a growing army of people who are helping us spread the word and support each other. So please go on our website and apply. And we'll have a training in June virtually, so it's nice and easy to join. If you are able, we appreciate any donations that people would make to the Family Heart Foundation. We are a nonprofit research and advocacy organization, and we depend on those donations to put on programs like this and do trainings and education. You can visit our website and make a donation anytime, 24 hours. And finally, just thank you so much for being on. We really appreciate you.